Here on Game Changers, we're all about helping you stay ahead of pharmacy practice. But why stop at listening? You can earn CE credit for this episode and hundreds more by visiting CEimpact.com and logging into your account or creating a new one. Get credit, get inspired, and make your learning count.
Hey, CEimpact subscribers. Welcome to the Game Changers Clinical Update podcast. I'm your host, Rachel Maynard. Today, we'll be looking at recent changes in the prevention and treatment of sexually transmitted infections, or STIs. And I'm really excited about this topic. There's been a bunch of potentially practice-changing updates in the last year or so that we need to know about as pharmacists. And specifically, we'll be looking at 2 new oral medications for treating gonorrhea. We'll also discuss how there's more awareness about the use of doxycycline post-exposure prophylaxis to prevent certain STIs after sex, also called doxyPEP, and a change in thinking for managing partners of patients with recurrent bacterial vaginosis. So lots of big changes we'll be looking at. And to help us navigate those changes and understand how they'll impact our practice, I'm very excited to welcome Dr. Franco to the program today. So welcome, Francisco. So happy to have you.
Thank you so much, Rachel, for the invitation. Very happy to be here.
All right. Well, very good. And I know you have some unique background and some expertise to bring to this discussion. So if you wouldn't mind just sharing a little bit about your background, where you currently are, and why you're passionate about this topic.
So I am a registered store manager for Walgreens Specialty in St. Louis. And the site that I'm at is a unique site. We are inside a doctor's office. In this doctor's office that we collaborate with primarily serve the LGBTQIA plus community. So most of our patients that are seen at the clinic are also seen by us at the pharmacy. We provide a lot of HIV care, either for both treatment and prevention. And we also work with our sexually expensive patients. So we provide a lot of gender affirming care, hormone replacement therapy, and things of that nature. So it's a passion of mine. I love these. I love working in my community and serving the people in my community, and that's what we do every day.
That's fantastic. So I'm very excited to hear. I'm sure you like jumped on this topic when you saw it, and you were like, "This is right up my alley." So
this is our bread and butter. We talked about this almost every day.
Excellent. Well, very excited to hear your perspective on this. And I mentioned a few of these key changes. We sort of had these 3 topics that we wanted to talk about. And with all of these, thinking about where we sort of have been and maybe where we're going and what we need to know and implement in practice. So let's start with those new treatments for gonorrhea. And can you give us an overview about what these oral options are, what they are going to bring to the table, how they work, if they, any particular considerations we need to be thinking about in terms of place and therapy for these?
So these new oral agents that we have, it's one is named soliflodacin and the other one gipotidacin. There are new oral options for the treatment of gonorrhea, while prior, the only treatment available was just an intramuscular injection.
Ceftriaxone, right?
The ceftriaxone injection, yep. Right? So yep. What we're looking at is what these new options are looking at is options for people that may not have the access to get an immediate intramuscular injection right away, or if they have any kind of needle phobia, or perhaps they're not nearby any healthcare system or any, for example, if they're doing a telehealth visit, how are they going to get treatment right away? So an oral option actually becomes very prominent and prevalent in those areas. Mm-hmm. For soliflodacin is it basically disrupts bacterial DNA synthesis, and gipotidacin the same way. They have similar mechanism of actions. While the chemical structures are different, they're considered novel agents for the treatment of gonorrhea.
I think they're both first in class, right? Like they're first in their class. And I think just to touch on that a little bit more, I think that's an important consideration. It sort of got some headlines simply because of the resistance rates that we're seeing with traditional gonorrhea treatments. So I think that's gotten some attention for that reason.
Because of the long-standing treatment of ceftriaxone and how these new molecules actually work, they've actually been able to cross that resistance that we have observed. These agents, while they're oral agents. They're easy to use for most people that may not have any kind of like swallowing issues. The benefit with sulflodacine is that it's a single dose. It's a packet that comes in a 3-gram dose that you create a suspension and you drink it with about 4 to 8 ounces of water. It is indicated for adults 12 years and older, and that weight at least 35 kilograms.
Okay.
For gipotidacin, it's also an oral agent. You do it as 2 different doses. You do 3 grams now, and then 12 hours later, you will do another dose. There is a limitation in terms of weight. You need to weigh at least 45 kilograms in order to be able to qualify for gipotidacin, but also indicated for adults or people over the age of 12 years old.
Okay. Okay. So it is nice to have these oral options, as you said, because there can be various reasons why the injectable ceftriaxone is not available or not desired by a patient, perhaps. So the oral options are nice. And it's also nice that it's either 1 dose for the zoliflodacin or the 2 doses, 12 hours apart for the gepotidacin. We're both practicing those names, getting used to them as these new drugs. But yeah, so I think those are good things to be aware of. And again, with the increasing concerns around resistance with gonorrhea, I think there's been a lot of interest in trying to develop and get new antibiotics approved to just expand the treatment options. So one thing with the zoliflodacin that I noticed is some of these pregnancy concerns, so not to be used in pregnancy, that if you can get a partner pregnant, you need to use effective contraception. And maybe you can speak to that. I see you.
Yeah, definitely. Definitely watch out for persons that have the capacity of getting pregnant, and not to be used for 3 to 6 months after treatment. So you would definitely have to use either a secondary method of contraception for that time. And during that time, if there is a risk of pregnancy, we can explore other options for the treatment of gonorrhea. Maybe we can just do the azithromycin 1 gram if needed be at that time. But these agents work really well. Other considerations to have is that for patients that may be taking CYP3 and 4, moderate to like heavy inducers, that may actually decrease the effectiveness of both of these medications.
Okay.
So something to also to consider. And apart from the regular common side effects that you experience with most common antibiotics, just something to just watch out.
So yeah, sort of not necessarily any unique side effects, common side effects that stand out, but being aware of these interactions as a concern with the zoliflodacin, the pregnancy considerations, and using effective contraception, even though it's just that 1 dose for several months afterwards, is super important, I think. Yeah.
Yeah. Another note is for gipotidacin, according to the FDA indication, is for people that have limited or no other alternatives. So it's not going to be your first go-to option, which also is going to limit access in terms of insurance, because the cost of the medication is not that cheap. Even with a GoodRx, you're still looking at several $100s for that 1 treatment. So keeping in mind, if we need to go to sulfidacin, would probably be your go-to, and then gipotidacin would be your secondary option if sulfidacin is not an option for that person.
Yeah, thank you for calling that out, because it is interesting that the labeling does specify for the gepotidacin that's only sort of a last resort option when other treatments are available. So important to call that out. Now, you did also bring up the important consideration of cost. I'm curious if you've seen these in your practice already, and if access and cost is a barrier that you're running into, because certainly this is something we want treated quickly, effectively, and we don't want any delays in treatment. So how has that been seen working out?
I haven't seen gipotidacin yet. We had a patient that we tried to get sulfidacin covered. And after a prior authorization attempt, it just didn't go anywhere. So, and they were very hesitant to get the intramuscular injection.
Okay. Yeah.
So we went with a alternate method of using azithromycin, knowing that that may have not covered for the full instance at that time. And we just had the patient come back within a week to get them retested and then identify if we needed to like retreat again.
Yep. Okay.
But sulfidazine, I haven't seen gibberellizine yet, but sulfidazine, at least for this one time that we try to get it covered in our work.
Got it. Okay. Well, that's good perspective to know. Real world experience there.
It is. There's a couple options, but it is available. You can order it right away. But cost and what insurance may cover may be a barrier for some people.
Yeah. Yeah. Okay. So, and the other thing, just to mention quickly about the gepotidacin, I think we might have talked about that on a prior podcast. It's also approved for uncomplicated UTIs in certain patients as well. So this gonorrhea approval was a later indication. So if you may see it for other uses too. And I just wanted to mention that.
Absolutely.
Yeah. So would you say that these two new oral options, you laid out very clearly that the gepotidacin is specifically for sort of last resort, last line when other options aren't available. We talked about a little bit broader role for the zolidiflacin. You know what I mean? And so would you say that either of these are replacing the current standard of care, which is that injectable ceftriaxone, or is that sort of your still go-to for most patients?
I think the big takeaway from here would be that ceftriaxone still remains as a treatment of choice for gonorrhea, uncomplicated gonorrhea treatments. But now we have these two other options, which gives us a little bit of something, a wiggle room for us to play. The dosing is going to be different. We just have to look at safety consideration and access, but it's going to be our gold standard. For this kind of
ceftriaxone is still going to be the gold standard. Yep. Okay. Yeah. Good bottom line summary there. And I think it'll be interesting to see too, because again, over the past couple of decades, the resistance concerns with gonorrhea have sort of grown and continued to be a concern. And so treatment recommendations have changed over time. So even though these are new options, it will be also important to see how those resistance concerns come into play with these as well.
Absolutely.
All right. Well, very good. Nice summary there. Let's move on to that second topic of doxypep. So the idea of having patients use this post-exposure prophylaxis with doxycycline after sex, and it's only for specific groups of patients and in specific scenarios. So maybe you can just get us all up to speed on what this doxypep option is.
So doxypep stands for doxycycline post-exposure prophylaxis. And it's intended to be taken within 72 hours after unprotected sex with the hope to reduce bacterial STIs, so sexual transmitted infections, mostly looking at syphilis and chlamydia. And in some instances, it may cover gonorrhea about 50% of the time. According to the CDC recommendations, people that are identify as gay, bisexual, or men who have sex with men, and transgender women that have had at least one STI in the previous 12 months should be offered doxypep. And in my personal note, I would probably add that any sexually active person that have had at least an STI in the previous 12 months should be considered for doxypep as well.
Yeah. So to clarify, that's the CDC recommendations, and there are guidelines from CDC about doxypep specifically. And as you said, they recommend at least having the discussion in men who have sex with men and transgender women. They have not gone beyond those populations yet, but I think that's simply due to lack of data. And so what I'm hearing you say is that you would consider having the conversation with other patients as well.
And we do. We have conversations with our patients, cisgender women, heterosexual men that have had at least one STI over the previous 12 months. We'll have that conversation of like what that looks like, and then perhaps looking at other options. Even though it's not recommended by the CDC, I think for sexual health, it's important to have that conversation.
Well, and for lots of reasons too, because that opens the door to a lot of other preventive discussions and screening and all of that you can sort of go ahead.
No, exactly. You know, if the recommendation for like example for HIV PrEP is that you have had at least one STI in the previous 12 months. So if we're gonna if we're gonna be recommending doxypep, we should also have that conversation for HIV PrEP as well.
Yep, absolutely. And yeah, I was thinking about the relationship between doxypep as an analogous sort of method to HIV PEP, post-exposure prophylaxis. That's a very different sort of situation.
Yeah.
You're absolutely right. Doxypep is a greater link to HIV PrEP, pre-exposure prophylaxis, and encouraging patients to take a preventive measure to prevent HIV transmission.
Mm-hmm.
So that's very good call out there. So tell us about how doxypep works and how it's taken, what patients need to know about the actual regimen.
So doxypep is dosed as 200 milligrams that you take by mouth for one dose. Usually it's dispensed as two 100 milligram capsules. So it's two capsules you take as one dose. You're going to take it as soon as possible after you've had unprotected sex and no later than 72 hours. So that you have that 72-hour window after you've had either oral, vaginal, or anal sex.
Okay. So again, that's where my mind was going with the HIV post-exposure prophylaxis, because it's similar. You take it after, well, yeah, as soon as possible is when you need to start it, but it's longer duration. Obviously, it's not that one dose like we're talking about with this doxypep. So this is one dose after unprotected sex. And my understanding is that it can be taken as often as needed after unprotected sex, as in it's not like one and done. You can have repeat doses post-exposure prophylaxis.
You just don't want to take more than one dose within 24 hours. So the minimum window between doses would be 24 hours. So if you've had unprotected sex today and then you have unprotected sex tomorrow, if it's been more than 24 hours since your last encounter, you can go ahead and take another dose.
Okay. And ideally as soon as possible, but again, at least within 72 hours is when you'd want to take it.
Absolutely.
Okay. And you mentioned it is effective primarily for syphilis and chlamydia and mixed data on gonorrhea. So, and again, thinking about other preventive measures here, I'm assuming a lot of your conversations are also around protected sex and safer sex options like condoms. And what other strategies do you typically talk about with patients when you are working with them on this?
We ask about what basically their sexual activity looks like. Do we have one partner? Do we have multiple partners? Do we know who our partners are and what their sexual activity looks like? So we're looking at protecting you, but also protecting your sexual partners as well. And then we look at the previous history of things that may have been happening in the past. And we try to look at what things we can do to help you prevent reoccurrence of these. We also encourage STI testing every 3 to 6 months, depending on what your sexual activity or your sexual partners are. But also being aware that, this is not going to be a silver bullet that's going to protect you from everything, right? So at times, if we are unsure of what the situation is, using safe sex practices would be the best protection that we can ever have.
Right. And I guess just to clarify, this doxypep, is it only if there was an instance of unprotected sex, or if say condoms were used, that would a patient still consider it in that scenario? Or is it really for if you're concerned about, say, a broken condom, for example?
For my patients that may be unsure of what may have happened during that encounter,
Yeah,
it's better to be safe than sorry later. So if there is any kind of doubt, just go ahead and take your dose just to be safe in that instance.
And so that's a good transition into some of the safety considerations too with this regimen. So in terms of using it when needed and as soon as possible after sex, unprotected sex, what are the safety considerations with those single dose options and or if people are using it repeat times?
So a couple of things to be aware of, just like doxycycline is an antibiotic. So the GI upset, the vomiting, diarrhea, maybe a little bit of discomfort will potentially happen. The other thing to watch out with doxypep is that doxycycline causes photosensitivity. So therefore, if we are in the summer times and we're out and about, we definitely have to use an extra layer of like sunscreen protection.
Mm-hmm.
And
Mm-hmm.
if it's the winter time and you're out on vacation on a tropical cool place, make sure that you bring your sunscreen because you're definitely going to be a little bit more sensitive to the sun during those times. You
Yeah.
have to make sure that you drink your dose with at least a full glass of water, so that medication actually gets in your stomach. And the other consideration is for people that take multivitamins, because other these cations like calcium,
Mm-hmm.
iron, magnesium, and zinc can actually chelate to the doxy and actually make it less effective. So we
Mm-hmm.
want to make sure that we space those out, but at least an hour.
Mm-hmm. Mm-hmm. And that is, I think, an important consideration because people may not think of this the same way as they would with an antibiotic that they might take for several days, for example, where you sort of get that routine education and you read the labeling and you see it interacts. But if you're just taking this as a one-off, especially as soon as possible after sex, then you might
Mhm.
not be thinking about some of those considerations.
100%. And we do emphasize that to our patients because for that same reason, antibiotic, you
Yeah.
get used to the regimen for 5 to 7 days, and you can't do certain things with that one dose. Then, you grab a piece of cheese or eat some yogurt later, right after, and you're like,
Right,
well,
right.
you just kill your dose.
Yeah, yeah, right, right. So again, another good reminder for important, education and administration points, but also that this is not a silver bullet, as you said, and that we still want to be ensuring other preventive measures are being taken, the screenings are being taken, that follow-up is being taken. Is there a recommendation around how often to follow up with patients if they are getting this on a regular basis and what that looks like?
We definitely, most of the patients that we see in our clinic, we make sure that they are coming back to clinic for STI testing every 3 to 6 months,
Okay.
just to make sure that, that we are covering all of our bases.
Yeah.
And there is treatment that needs to happen that we can go ahead and do that. We know that sometimes, and for some people, STIs can go unnoticed for a
Right.
while,
Right.
right? Some
Right.
people don't show symptoms right away, and it could be a couple months before they can actually show symptoms. So being proactive with your sexual health is the best recommendation that we have for our patients.
That's great and really good reinforcement there. And again, especially as people are coming back potentially for refills of the one-time doses, having those conversations ongoing.
Yeah. Yeah, we since we do a lot of HIV prep in our clinic, a conversation that my technicians have been trained to, in like my pharmacist, is like, if when was the last time you actually got your doxypep?
Mm-hmm.
And then we look at their like refill history and be like, hey,
Mm-hmm.
are you good with it? Do you need a refill around at this time? So that way, when you come
Mm-hmm.
and pick up your prep, we'll have your doxy available for you at the same time. And the same for the patients. We do injectables in our clinic,
Mm-hmm.
like
Mm-hmm.
uh, Cabenuva and Aperture, like these
Mm-hmm.
other injectables. And,
Mm-hmm.
we make
Mm-hmm.
sure that our patients also get their treatments whenever they come for their injections as well.
Yeah, that's great in terms of being proactive and asking about it and letting it not fall off the radar just because maybe you haven't needed it in a while.
In a while, absolutely. Yeah. It's
Yeah.
something that we can get for you at your next visit right away.
That's great. I love that proactive approach. Okay, so very nice overview of DoxyPep. I think we're up to speed on that one. And now let's move on to that third topic, which is about recurrent bacterial vaginosis and some new data that we have around treating partners of these patients with recurrent bacterial vaginosis. So I'll let you chat about that a little bit, get us up to speed there.
So something that we have traditionally thought of bacterial vaginosis, it's what we call in medical terms, vaginal dysbiosis. So it's just thought that it's just the microbiome of the one individual that perhaps goes off at different times, and that just leads to the overgrowth of bacteria, leading to the bacterial vaginosis. But there's been some epidemiological data from the CDC and other labs that have shown that bacterial vaginosis associated bacteria has been found on sexual partners of someone that has had recurrent bacterial vaginosis, not only in male partners, but also in female sex partners, which
Mm-hmm.
was huge because then it showed that there is transmissibility of the
Mm-hmm.
bacteria from one partner to another, which
Mm-hmm.
can potentially lead to that is where the recurrence is actually happening, right?
Mm-hmm. Mm-hmm.
So this is where all of these data started coming up, and there was a study that was published in 2025 at the New England Journal of Medicine called the Step Up Trial. And this is where they were looking at, they had two arms, one where they were just treating just the female partner, and then in the other one, they were treating the male partner with a antibiotic treatment. And they actually stopped the study early because the data and the safety monitoring was so good that they're like, no, listen, this is where we need to go, and we're gonna show this data. So what they showed was that doing the not only doing the partner treatment with an antibiotic by mouth and then also a topical antibiotic actually reduce the recurrence of bacterial vaginosis almost completely. And that's just where that new recurrence data is coming up. So we know now that there are other options that we can use to treat bacterial vaginosis. Not only the female can get treated, if we actually treat the male partner or the female other partner, we can actually prevent or stop the recurrence.
Yeah, so I feel like this is potentially practice changing in a couple of ways, that the idea of treating the male partner or even female partner, as you said, treating the partner is something that has not historically been done. You know, we've seen that for other STIs where you might treat the partner if one patient is diagnosed, the other partner might be treated. But this is something, bacterial vaginosis has not historically been thought of as an STI. And so, like you say, that there's that thinking is changing a little bit. And I think these data that New England Journal study is sort of raising that question too, because if we're seeing efficacy in treating the partner in reducing the risk of recurrence in the patient, that suggests that this, as you said, transmissibility is sort of a consideration that maybe wasn't well recognized before.
Yeah, I think the part that we didn't know was that noticing that the bacterial vaginosis associated bacteria was found in similar partners, especially the cases where monogamous female partners was the key for people to say, wait, hold on, there is reinoculation happening here.
Yeah.
So we need to stop the reinoculation. We will definitely can stop the recurrence.
Yeah. And I saw a stat up to 2/3 of women patients have recurrence of bacterial vaginosis within a year of being treated. So it's a common problem. And that's why this is a big deal, because if we have an option to help prevent that recurrence, that could be game changing for some patients.
For a lot of people, and it will be a game changing on your day-to-day activities, not having to think about that, oh, I'm gonna get, if people that perhaps are being less active or being less open about their sexual activity and their sexual life, they may be stopping themselves from actually having sexual encounters with their actual partner for the fear of getting a bacterial infection, right? So that can actually lead to problems in your actual relationship problems that, if we can prevent all of that, then we may actually develop or prevent some of the other, relationship issues that may add on stressors into a relationship. And we know that relationships are difficult just by the nature of how they are. So eliminating some of the stressors can actually like help out some of these couples in general.
Right. So when would you think about discussing this with your patients? Say you find out in one way or another, they share with you, or you're seeing them getting treatment for bacterial vaginosis. When would you think about having this discussion around treating the partner potentially?
Usually, we have this conversation if we've had 2 or more recurrence of bacterial vaginosis within 3 months. That's kind of like for us at the clinic, that's kind of like what we look at. Is it the best method? I don't know if it's the best method. We've never studied it, but this is like something that we just keep in mind. Like if we treated them like within 3 months for the same bacterial vaginosis, like, hey, let's talk a little bit more about this. What's happening? Are we in a monogamous relationship? Do we have an open relationship? what's happening at home, what are your sexual practices. Maybe we can explore a little bit more about a variety of different things and then offer an option. We
Hmm.
do, I remember when this study came out, we were talking about in clinic, and some of our providers were like, oh my God, this is going to be a game changer, because we've had these patients that come
Yeah.
every month, or they call us every month for another
Wow.
course of antibiotic, another course of
Wow.
antibiotic. And they were like, okay, we have an option that we can use for some of our patients right now. And we've actually been using this for a little while, for a couple of our patients, and has definitely helped.
That's great. That's very empowering to hear, because it is something that is making a real difference in patients' lives, especially if they have struggled with this for maybe years and never
Mhm.
had a good solution.
Yeah. People that have just accepted the fact that this is what their
Right.
life is, it
Right.
is very line changing, and a game changer, that you don't have to live with this every day. We
Yeah.
have options that can actually help.
Yeah, yeah, that's excellent. So and it's great to hear that you're already seeing this and seeing the benefits of this in practice. So it is a potentially practice changing set of evidence that we can now leverage those discussions with patients with. And I do want to talk about those conversations, because it seems like you have a very good handle on how to have some of these difficult conversations with patients and open the door to that discussion. So any advice for our listeners on best practices for helping set the stage and make the patient feel comfortable, ensuring that they have a safe space? What tips do you have around that?
I usually start with, how are we doing? Are we doing okay? And how are we feeling today? And I will follow up with, like, I noticed that this is that we've dispensed this medication for you, a couple of times within the past few months. Tell me about, how do you think this is coming along, right?
Hmm.
Do you have any triggers? Have you noticed anything different?
Hmm.
And then try to explore, and then just like keep opening questions of, like, okay, are we in a monogamous relationship? Do we have an open relationship? Do we know who our partners are? Do we have any concerns about any of our partners? And then following up is like, we want to make sure that you get the adequate treatment, but if we can actually help you, prevent you from this happening again, these are the options that we have. And then is this something
Hmm.
that you may be interested in?
Hmm. Hmm. Okay. Yeah, I think it's often just practice too, and getting used to once patients respond. I'm sure you've seen that it's probably very rewarding for you, I would imagine.
Yeah, some people get a little hesitant to when someone is asking about their sexual activity, and then their sexual partners. But in our clinic, it's something that we do on a daily basis.
Hmm. Hmm. So
So
it's routine. Yeah.
yes, I tell the patients, like, listen, there's very few things you can tell me that are gonna shock me. So
Hmm.
you can go
Hmm.
ahead and tell me, because I'd rather have all of the information that I
Right.
need so I can actually provide you with the
Hmm.
best answers that you can have.
That's excellent. Again, it's putting the power in their hands. We're
Mhm.
trying to help, and we just need the
Absolutely.
information to be able to do that properly.
Absolutely. Absolutely.
Yeah. Well, to wrap up this topic, you did a great summary of these three key areas, and just thinking about how all of this is going to impact practice. And I know some of these changes aren't necessarily brand new, but some people may not be seeing too much of this yet, and we might continue to see traction being gained for doxypep, for example, or
Mhm.
the bacterial vaginosis, and even these new gonorrhea treatments. So where do you think pharmacists play the biggest role with all of these changes in supporting patients and optimizing care?
Um, so something that pharmacists need to remember is that we continue to be the most accessible healthcare professional there is. We are the ones that can actually have a lot more touch points with our patients,
Hmm.
and then utilizing these opportunities to capitalize on potential gaps in care that our
Hmm.
patients may be experiencing. So if we have patients that we know that may be getting a prescription for a STI, we can look to make sure that they are actually, getting the full treatment, counseling them are the do's and don'ts, when taking these medications, what to watch out for, and then addressing any other questions and concerns that they may have, and also to know when to refer. Right. So it's always very important. And something that we learn in pharmacy school is like, you create your differential and you know when to treat and when to refer. And providing that opportunity for them to actually see a provider that can actually have an opportunity for them. But for us to have the knowledge that, the treatments have changed, that we not only have the gold standard of the ceftriaxone for gonorrhea as intramuscular injection is still going to be the preferred method, but patients, they have other options right now. We can use oral options that we can have. Same thing for doxycycline. People that have other options to treat and prevent STIs, it's available now. And for our female patients that may have this recurrent of a bacterial infection that happens, they're not alone in this anymore. We can actually treat their partner so we can actually reduce the recurrence of that. But it just all happens with conversation and making sure that we have an open and honest conversation with our patients. And then we can give them the variety of options and then give the patient the autonomy and the self-determination for them to make a decision and empower them to make those decisions as well.
That's an excellent bottom line. You summarized it so well, all of these key changes. And as you said, I think having more options is always a good thing, to have other sort of menu of options to be able to talk with patients about, but also just the fact that some of these are going to potentially improve accessibility, but also considering some of those cost concerns that might come up with some newer options, for example, but just empowering patients, as you said, with more ways to prevent and treat STIs when possible. And I think we can all be thinking about patients in our care that could benefit from some of these options and just being aware of them as potential considerations to be talking about.
Absolutely. I think it's just giving the option to the patient to make an informed decision is the best that we can do for our patients.
Absolutely. So the role of pharmacists continues to evolve with all these changes coming out. And so I really appreciate you summarizing this and bringing us, up to the latest evidence and what we need to know about it in our practice. It is our Game Changers podcast. So we always wrap up with what the game changer is. And so what would you say is the game changer you'd want our listeners to walk away with?
That one size does not fit all, that we do have options for our patients, and providing them with the most up-to-date information there is for them to actually make an informed decision is the best that we can do for our patients and continue to do on a daily basis for them.
Fantastic. Thank you so much, Francisco. Your expertise and your personal perspective here was really empowering and educating. So thank you. Really appreciate your time.
Thank you, Rachel, so much for the opportunity. I'm very happy and excited to be here with you guys.
Fantastic. Thank you. Well, we talked about a lot of great practical tips today, and those will be summarized in the practice resource that goes along with this podcast on the CEimpact website. So feel free to access that and take it along to remember some of the great things we talked about today, listeners. Otherwise, be sure to claim your CE credit for this episode of Game Changers by logging in at CEimpact.com. And as always, have a great week and keep learning. I can't wait to dig into another game-changing topic with you all next week.